Welcome to this continuing education course on functional neurological disorders for the non-specialist clinician. I'm delighted to guide you through this comprehensive exploration of one of the most common, yet historically misunderstood categories of conditions you'll encounter across healthcare settings. Functional neurological disorders, which we'll often refer to as FND throughout this course, affect 5 to 15% of patients seen in neurology clinics. To put that in perspective, FND rivals the prevalence of multiple sclerosis and Parkinson disease. Yet despite how common these conditions are, many healthcare professionals receive minimal training in recognizing and managing them. The consequences of this knowledge gap are profound. Patients experience prolonged diagnostic odysseys, inappropriate treatments, and dismissive encounters that compound their suffering and delay access to effective care. The good news is that the landscape of FND has transformed dramatically over the past 2 decades. Once relegated to the margins of neurology and psychiatry, viewed with skepticism, and approached primarily through exclusion of organic disease, FND is now recognized as a legitimate neurological condition with identifiable brain network dysfunction, validated positive diagnostic signs, and evidence-based treatment approaches. Contemporary neuroscience has established that FND symptoms arise from abnormal functional processing within intact neural structures. This explains why these symptoms are genuine, involuntary, and amenable to targeted rehabilitation interventions. For physical therapists, occupational therapists, speech-language pathologists, nurses, and other allied health professionals, competency in FND is not optional, but essential. You encounter patients with FND regularly, whether in acute care settings, outpatient rehabilitation, community health centers, or specialized neurological services. You may be the first to recognize when functional symptoms are present. You may be the primary provider delivering evidence-based rehabilitation. Or you may be the professional maintaining the long-term therapeutic relationship that supports sustained recovery. Your role in early identification, appropriate referral, and collaborative multidisciplinary care directly influences patient outcomes. This course provides a comprehensive, evidence-based foundation for understanding and managing FND in adult populations. We'll begin with the conceptual foundations of FND pathophysiology within a biopsychosocial framework. From there, we'll progress through positive diagnostic approaches using validated clinical signs, then explore multidisciplinary rehabilitation strategies supported by randomized controlled trial evidence. We'll examine principles of long-term management and outcome measurement, consider implementation challenges and emerging therapies, and finally apply everything we've learned through detailed case studies. Throughout, the emphasis will be on practical knowledge that translates directly to your clinical practice. This course reflects the contemporary shift toward positive rule-in diagnosis that empowers you to make the FND diagnosis with confidence based on what you find rather than what you exclude. We'll address the critical importance of destigmatizing FND, communicating the diagnosis in ways that validate patient experience and promote treatment engagement, and integrating physical and psychological interventions within coordinated care frameworks. Before we dive into the content, let me share the learning objectives for this course. Upon completion, you will be able to differentiate between functional neurological disorder presentations, including motor, sensory, seizure-like, and cognitive symptoms, and organic neurological conditions based on positive clinical signs and established diagnostic criteria. You'll learn to apply validated rule-in clinical signs, including Hoover's sign, tremor entrainment, and tubular vision, to support the positive diagnosis of functional neurological disorders across symptom domains. You'll be able to analyze the biopsychosocial mechanisms underlying functional neurological disorders, including the role of abnormal brain network function, predictive coding, emotional arousal, and psychosocial risk factors, to inform patient-centered clinical reasoning. You'll evaluate the efficacy of multidisciplinary rehabilitation strategies, including physical therapy, occupational therapy, cognitive behavioral therapy, and psychoeducation, for adults with functional neurological disorders based on current randomized controlled trial evidence. You'll select appropriate validated outcome measures and quality of life instruments for monitoring treatment response and functional progress in patients with functional neurological disorders. You'll assess barriers to effective implementation of multidisciplinary care for functional neurological disorders in clinical practice and determine strategies to enhance care coordination, patient engagement, and treatment adherence. And finally, you'll compare emerging therapeutic approaches for functional neurological disorders, including neuromodulation and eye movement desensitization and reprocessing, with established evidence-based interventions to guide clinical decision-making for refractory cases. Now let's begin our journey through this material with our first module on the foundations of functional neurological disorders. Functional neurological disorders represent one of the most common, yet historically misunderstood categories of neurological conditions encountered across healthcare settings. For decades, these disorders occupied an uncertain territory between neurology and psychiatry. They were often dismissed as psychogenic, hysterical, or even fabricated. This legacy of misunderstanding has contributed to diagnostic delays, therapeutic nihilism, and significant patient suffering. However, the past 2 decades have witnessed a fundamental transformation in how clinicians and researchers conceptualize, diagnose, and treat these conditions. Contemporary neuroscience has established FND as a legitimate neurological disorder with identifiable brain network dysfunction, validated diagnostic signs, and evidence-based treatment approaches. For non-specialist clinicians working in rehabilitation and allied health settings, understanding the foundations of FND is essential. These patients frequently present to physical therapists, occupational therapists, speech-language pathologists, and nurses, often before a formal diagnosis has been established or after being discharged from neurology services with limited guidance on ongoing management. This first module establishes the conceptual framework necessary for understanding FND as a genuine involuntary condition amenable to targeted rehabilitation interventions. Let's start by defining exactly what we mean by functional neurological disorders. FND is now recognized as a group of genuine involuntary neurological conditions characterized by symptoms that are incongruent with recognized organic neurological disease and are diagnosed on the basis of positive clinical signs rather than exclusion of other pathology. The term functional reflects the contemporary understanding that these disorders arise from abnormal functioning of brain networks, rather than from structural damage, degeneration, or inflammation. This terminology has largely replaced older terms such as conversion disorder, psychogenic, or hysterical, which carried pejorative connotations and implied that symptoms were psychological in origin or under voluntary control. The spectrum of FND is broad and encompasses multiple symptom domains. Motor symptoms include limb weakness, paralysis, tremor, dystonia, myoclonus, and gait disturbances. Sensory symptoms include numbness, paresthesias, and visual or auditory disturbances. Seizure-like events, termed psychogenic non-epileptic seizures or functional seizures, represent paroxysmal episodes that resemble epileptic seizures but occur without the abnormal electrical brain activity characteristic of epilepsy. Cognitive symptoms, including difficulties with attention, memory, and executive function, and speech disturbances such as dysarthria or aphonia, also fall within the FND spectrum. A critical principle for you to understand is that FND symptoms are involuntary. Patients do not consciously produce or control their symptoms, and the experience of disability is genuine. This distinguishes FND from factitious disorder, in which symptoms are intentionally produced for psychological reasons, and from malingering, in which symptoms are fabricated for external gain, such as financial compensation or avoidance of responsibilities. The involuntary nature of FND symptoms is supported by neuroimaging evidence demonstrating abnormal brain activation patterns during symptom production and by the clinical observation that symptoms often persist even when there is no apparent secondary gain and when patients are highly motivated to recover. The Diagnostic and Statistical Manual of Mental Disorders, 5th edition, text revision classifies FND as functional neurological symptom disorder, also known as conversion disorder, and requires the presence of one or more symptoms of altered voluntary motor or sensory function, incompatibility between the symptom and recognized neurological or medical conditions, and clinical findings that provide positive evidence supporting the diagnosis. The International Classification of Diseases 11th revision similarly classifies these conditions under dissociative neurological symptom disorder, with subtypes corresponding to motor, sensory, cognitive, and seizure presentations. Both classification systems emphasize that the diagnosis should be made on the basis of positive clinical findings rather than simply excluding organic disease, and both acknowledge that FND can coexist with other neurological conditions, such as epilepsy or multiple sclerosis. Now let's consider the epidemiology and socioeconomic burden of these disorders. The prevalence of FND is substantial, and these disorders represent a significant proportion of the caseload in neurology clinics and emergency departments. Studies consistently report that FND accounts for 5 to 15% of patients seen in outpatient neurology clinics, making these among the most common conditions encountered by neurologists. The annual incidence of FND is estimated at 4 to 12 per 100,000 population, which is comparable to the incidence of major neurological diseases such as multiple sclerosis and amyotrophic lateral sclerosis. The demographic profile of FND reveals important patterns. These disorders are most common in young and middle-aged adults, with peak onset typically occurring between the ages of 20 and 50 years. There is a consistent female predominance across most FND subtypes, with women representing approximately 60 to 75% of affected individuals in most clinical series. However, the sex ratio varies by symptom type. Functional seizures show the strongest female predominance, while functional movement disorders show a more balanced distribution. FND can occur at any age, including in children and older adults, though the presentation and prognosis may differ across age groups. The socioeconomic burden of FND is considerable and often underappreciated. Patients with FND experience levels of disability and reduced quality of life comparable to or exceeding those seen in patients with structural neurological diseases such as Parkinson disease or multiple sclerosis. A substantial proportion of patients are unable to work, and many require ongoing assistance with activities of daily living. The economic impact extends beyond individual patients to healthcare systems, with FND associated with high rates of emergency department utilization, inpatient hospital admissions, and consumption of diagnostic resources. Research examining healthcare utilization patterns has demonstrated that adults with FND have significantly higher rates of emergency department visits and inpatient admissions compared to patients with other neurological disorders. A large-scale analysis of national inpatient and emergency department databases found that FND admissions were associated with longer lengths of stay, higher costs, and greater utilization of advanced diagnostic testing compared to admissions for many organic neurological conditions. Patients with FND also had higher rates of comorbid psychiatric diagnoses, including depression, anxiety, and post-traumatic stress disorder, which further complicate management and contribute to healthcare costs. The burden of FND falls disproportionately on certain populations. Individuals from lower socioeconomic backgrounds experience higher rates of FND and face greater barriers to accessing specialized care. Socioeconomic disadvantage increases exposure to psychological stressors, childhood adversity, and chronic health difficulties, all of which are established risk factors for FND. Additionally, patients from disadvantaged backgrounds may have less access to the multidisciplinary rehabilitation services that represent the standard of care for FND, potentially contributing to worse outcomes and greater chronicity. Now let's turn to understanding the pathophysiology of FND through the biopsychosocial framework. Understanding the pathophysiology of FND requires moving beyond the historical dichotomy between organic and psychological illness toward a biopsychosocial framework that integrates neurobiological, psychological, and social factors. This framework recognizes that FND arises from the interaction of predisposing vulnerabilities, precipitating events, and perpetuating factors operating across biological, psychological, and social domains. Neuroimaging and neurophysiological studies have provided compelling evidence that FND is associated with abnormal brain network function, particularly involving the limbic system, prefrontal cortex, and motor regions. Functional magnetic resonance imaging studies have demonstrated altered connectivity between emotional processing regions, including the amygdala and insula, and motor control regions in patients with functional motor symptoms. These findings suggest that emotional and attentional processes exert abnormal influence over motor function in FND, leading to the involuntary production of symptoms. One of the most influential contemporary models for understanding FND pathophysiology is the predictive coding or Bayesian brain framework. This model posits that the brain continuously generates predictions about expected sensory and motor states based on prior experience and current context. Under normal circumstances, these predictions are updated based on incoming sensory feedback, allowing for flexible and adaptive behavior. In FND, abnormal internal predictions, or what we call priors, are thought to override normal sensory feedback, leading to the experience and production of symptoms that are inconsistent with actual peripheral function. The predictive coding model has important clinical implications. It suggests that FND symptoms arise from the same neural machinery that governs normal voluntary movement, but are driven by abnormal top-down predictions rather than by conscious intention or peripheral pathology. This explains why FND symptoms can appear identical to those produced by structural neurological disease, why they are experienced as involuntary by patients, and why they can be modified by interventions that alter attention, expectation, and belief. The model also helps explain why symptoms often fluctuate, why they may improve with distraction, and why they can be influenced by the manner in which the diagnosis is communicated and understood. Emotional arousal and stress sensitivity play central roles in symptom generation and maintenance in FND. Patients with FND often demonstrate heightened physiological and psychological responses to stress, increased activation of the autonomic nervous system, and altered processing of emotional stimuli. Neuroimaging studies have revealed increased connectivity between limbic structures and motor regions, suggesting that emotional states may directly influence motor output in ways that do not occur in healthy individuals. This does not mean that FND is simply caused by stress, but rather that the neural systems involved in emotional processing are abnormally coupled to motor systems in affected individuals. Interoceptive awareness, which refers to the perception of internal bodily signals such as heartbeat, breathing, and visceral sensations, is also altered in FND. Some patients demonstrate heightened interoceptive sensitivity and excessive self-monitoring of bodily states, which may contribute to symptom amplification and maintenance. This excessive attention to the body may interact with abnormal predictive models to generate and perpetuate symptoms. Conversely, other patients may demonstrate reduced interoceptive accuracy, potentially reflecting dissociative processes that disconnect awareness from bodily function. A comprehensive understanding of FND requires consideration of the risk factors and precipitating events that contribute to symptom development. These factors operate across biological, psychological, and social domains and vary considerably among individual patients. Psychological stressors and adverse life events are commonly reported in patients with FND, though they are not universally present and are not required for diagnosis. Studies consistently find elevated rates of childhood adversity, including physical, sexual, and emotional abuse, neglect, parental loss, and dysfunctional family environments in FND populations compared to healthy controls. Adult stressors, including relationship difficulties, occupational stress, financial hardship, and medical illness, are also frequently identified as precipitating or exacerbating factors. However, it is essential to recognize that the relationship between psychological stressors and FND is not straightforward. Many patients with significant trauma histories do not develop FND, and many patients with FND do not report identifiable stressors. The absence of identifiable psychological stressors does not preclude the diagnosis of FND and should not lead you to doubt the diagnosis when positive clinical signs are present. Contemporary understanding recognizes that FND can arise through multiple pathways and that psychological trauma represents only one of several potential contributing factors. Searching for a psychological cause in patients who do not spontaneously report stressors can be counterproductive, may damage the therapeutic relationship, and may inadvertently communicate that you don't believe the symptoms are genuine. Biological factors also contribute to FND vulnerability. There is emerging evidence for genetic predisposition, with studies suggesting heritability for functional somatic symptoms and demonstrating familial clustering of FND and related conditions. Developmental abnormalities of the amygdala and other limbic structures have been identified in some patients, potentially representing a neurobiological substrate for altered emotional motor coupling. Physical illness and injury can serve as precipitating factors, with a substantial proportion of patients reporting symptom onset following surgery, physical trauma, or acute medical illness. This has led to recognition of what we call functional overlay. in which functional symptoms develop in the context of or following organic neurological events. Psychiatric comorbidity is common in FND and represents both a risk factor and a complicating factor for treatment. Depression and anxiety disorders are present in a substantial majority of FND patients, with rates significantly exceeding those in the general population and in patients with organic neurological diseases. Post-traumatic stress disorder is also common, particularly in patients with histories of childhood adversity or adult trauma. Personality factors, including cluster B personality traits and alexithymia, which refers to difficulty identifying and expressing emotions, have been associated with FND in some studies. Importantly, psychiatric comorbidity in FND is associated with greater symptom severity, increased disability, and poorer response to treatment, highlighting the importance of addressing mental health needs as part of comprehensive management. The foundational concepts we've covered have direct implications for clinical practice in rehabilitation and allied health settings. Understanding that FND is a genuine neurological disorder arising from abnormal brain network function, rather than a psychiatric condition or fabricated illness, is essential for providing compassionate, effective care. This understanding should inform how you communicate with patients, how you approach assessment and treatment planning, and how you conceptualize the goals and mechanisms of rehabilitation interventions. The biopsychosocial framework emphasizes that effective management of FND requires attention to biological, psychological, and social factors across the continuum of care. For physical therapists and occupational therapists, this means integrating knowledge of FND pathophysiology into motor retraining approaches, understanding how attention and expectation influence symptom expression, and recognizing the role of psychological factors without reducing the disorder to a purely psychological problem. For speech-language pathologists working with patients with functional speech disorders, the framework highlights the importance of approaches that target automatic speech production and reduce excessive self-monitoring. For nurses and other allied health professionals, understanding FND as a legitimate disorder is essential for providing supportive, non-judgmental care and for educating patients and families. Now that we've established the foundational understanding of FND, let's move into our second module on clinical assessment and diagnosis, focusing specifically on rule-in signs and validated tools. The diagnosis of functional neurological disorders has undergone a fundamental paradigm shift over the past 2 decades. Historically, FND was considered a diagnosis of exclusion, made only after extensive investigation had ruled out all possible organic causes. This approach led to prolonged diagnostic odysseys, excessive testing, iatrogenic harm, and delayed access to appropriate treatment. Contemporary practice has moved decisively toward a positive rule-in approach in which the diagnosis is established on the basis of specific clinical signs that demonstrate internal inconsistency and incongruity with recognized neurological disease patterns. This shift represents one of the most important advances in FND care and has profound implications for how non-specialist clinicians approach assessment and contribute to the diagnostic process. For rehabilitation and allied health professionals, understanding the clinical signs that support an FND diagnosis serves multiple purposes. It enables you to recognize when FND may be present in patients who have not yet received a formal diagnosis. It facilitates appropriate referral. It supports clinical reasoning during treatment planning, and it helps you communicate confidently with patients about the basis for their diagnosis. The diagnosis of FND is grounded in established criteria from major classification systems and relies on the identification of positive clinical signs rather than the mere exclusion of organic pathology. The current diagnostic criteria emphasize that the diagnosis should be supported by positive clinical findings rather than based solely on the absence of organic disease. Both the DSM-5-TR and ICD-11 classification systems reflect the contemporary consensus that FND diagnosis should be made with the same confidence as other neurological diagnoses based on the presence of characteristic clinical findings. This represents a departure from earlier diagnostic approaches that required extensive investigation to exclude organic disease before considering FND. The rule-in approach recognizes that clinical signs of FND have high specificity, meaning that when present, they reliably indicate functional rather than organic etiology. This allows clinicians to make the diagnosis positively rather than by default. A critical principle emphasized in current practice is that FND can coexist with organic neurological disease. The presence of epilepsy does not preclude a diagnosis of functional seizures, and the presence of multiple sclerosis or Parkinson disease does not preclude functional overlay. Studies suggest that 10 to 25% of patients with FND have comorbid neurological conditions, and failing to recognize this overlap can lead to both underdiagnosis and overdiagnosis. The diagnosis of FND in patients with known organic disease requires careful clinical assessment and should be based on the same positive clinical signs used in patients without organic comorbidity. Let's now examine the specific rule-in signs for functional motor symptoms. The assessment of functional motor symptoms, including weakness, movement disorders, and gait disturbances, relies on the identification of clinical signs that demonstrate internal inconsistency, variability, and incongruity with patterns expected in organic neurological disease. These signs have been validated in multiple studies and demonstrate high specificity for functional etiology, with reported values ranging from 64 to 100%, depending on the specific sign in the population studied. Hoover's sign is one of the most well-established and clinically useful signs for identifying functional leg weakness. The test exploits the principle of synergistic contraction, whereby hip extension on one side is normally accompanied by reflexive hip flexion on the contralateral side. To perform the test, the examiner places a hand beneath the heel of the apparently weak leg while asking the patient to flex the contralateral hip against resistance. In organic weakness, the weak leg will show reduced or absent downward pressure during contralateral hip flexion. In functional weakness, the weak leg demonstrates normal or near-normal downward pressure during this maneuver, indicating that the motor pathways are intact and that weakness is present only during direct voluntary testing. The complementary aspect of Hoover's sign involves testing hip flexion in the weak leg, while the examiner monitors hip extension in the contralateral leg. Patients with functional weakness often demonstrate reduced effort during direct testing of the weak leg, but normal synergistic extension in the contralateral leg, further supporting the functional nature of the deficit. Studies report specificity values for Hoover's sign ranging from 90 to 100% when properly performed, making it one of the most reliable bedside tests for functional leg weakness. The drift without pronation sign is useful for identifying functional arm weakness. In organic upper motor neuron weakness, when a patient holds both arms extended with palms facing upward and eyes closed, the weak arm will drift downward and pronate due to the relative weakness of supinator muscles compared to pronators. In functional weakness, the arm may drift downward but typically does not pronate, or may drift in unusual directions not consistent with upper motor neuron patterns. This sign helps distinguish functional weakness from corticospinal tract lesions and has reported specificity values exceeding 90%. Give-way weakness, also termed collapsing weakness, refers to a pattern in which initial resistance to examiner force is present but suddenly gives way, often with a ratchet-like or inconsistent quality. The patient may demonstrate brief normal strength followed by sudden collapse of effort, or strength may vary markedly with repeated testing or with changes in examiner technique. While give-way weakness can occasionally occur in patients with pain or poor effort due to other causes, when present in conjunction with other positive signs and in the absence of pain-limiting behavior, it supports a functional etiology. The specificity of give-way weakness is somewhat lower than other signs, estimated at 64 to 97% depending on the clinical context, and it should be interpreted in conjunction with other examination findings. Functional movement disorders, including tremor, dystonia, and myoclonus, have characteristic features that distinguish them from organic movement disorders. Functional tremor is characterized by variability in frequency and amplitude, entrainment to external rhythms, and suppressibility with distraction. Tremor entrainment testing involves asking the patient to perform a rhythmic movement with the unaffected limb, such as tapping at a specified frequency. In functional tremor, the tremor in the affected limb will change frequency to match the tapping rhythm or will be suppressed entirely, whereas organic tremor maintains its characteristic frequency independent of voluntary movements in other limbs. Distractibility testing involves engaging the patient in cognitive tasks or examining other body regions. Functional tremor often diminishes or resolves with distraction, while organic tremor persists. Functional dystonia has several distinguishing features, including fixed posturing from onset rather than the mobile dystonia typical of organic forms, resistance to passive manipulation, inconsistent activation patterns, and onset following peripheral injury. Fixed dystonia, particularly fixed ankle plantar flexion or fixed fist posturing, is highly suggestive of functional etiology, especially when present from symptom onset, rather than developing over time as occurs in progressive organic dystonias. Now let's look at the assessment of functional sensory symptoms. Functional sensory symptoms, including numbness, paresthesias, and visual disturbances, are diagnosed based on clinical findings that demonstrate anatomical inconsistency or incongruity with known neuroanatomical pathways. Unlike motor signs, sensory examination relies heavily on patient report and is therefore somewhat more challenging to assess objectively. Nevertheless, several clinical signs provide strong support for functional sensory etiology. Midline splitting is one such sign. Sensory loss that splits precisely at the midline, with an abrupt transition from normal to absent sensation exactly at the sagittal plane, is inconsistent with organic neurological disease. The sensory innervation of the trunk has significant overlap across the midline, and organic lesions produce gradual transitions rather than sharp demarcations. Midline splitting of vibration sense is particularly useful. Vibration applied to the sternum or frontal bone should be perceived symmetrically regardless of unilateral sensory loss, since the bone conducts vibration to both sides. Asymmetric perception of midline vibration suggests functional sensory loss. Non-anatomical distribution is another key finding. Sensory loss that does not conform to dermatomal peripheral nerve or central nervous system patterns suggests functional etiology. Hemisensory loss affecting the face, arm, trunk, and leg in identical fashion is inconsistent with any single lesion location and suggests a functional basis. Similarly, sensory loss that stops abruptly at the shoulder, hip, or other joint boundaries rather than following anatomical distributions is characteristic of functional sensory symptoms. Tubular vision, also termed tunnel vision with non-expanding fields, is a classic sign of functional visual loss. In organic visual field defects, the area of preserved vision expands proportionally as the testing distance increases because the visual angle remains constant. In functional visual loss, patients often report a fixed area of preserved vision that does not expand with distance, resulting in a tube of vision rather than a cone. This finding is highly specific for functional visual loss and can be demonstrated at the bedside using confrontational visual field testing at different distances. Let's now discuss psychogenic non-epileptic seizures. These events, also termed functional seizures or dissociative seizures, are paroxysmal episodes that resemble epileptic seizures but occur without the abnormal electrical brain activity that defines epilepsy. Psychogenic non-epileptic seizures represent a common and important FND subtype, accounting for approximately 20 to 30% of patients referred to epilepsy monitoring units for refractory seizures. Accurate diagnosis is essential because treatment approaches differ fundamentally from those for epilepsy, and misdiagnosis leads to inappropriate anti-seizure medication use, medication side effects, and delayed access to effective psychological and rehabilitative interventions. The diagnosis of psychogenic non-epileptic seizures is based on semiological features that distinguish these events from epileptic seizures, supported by video electroencephalographic monitoring that demonstrates absence of epileptiform activity during typical events. Semiological features suggestive of psychogenic non-epileptic seizures include prolonged duration exceeding 2 minutes, fluctuating or waxing and waning intensity, asynchronous or out-of-phase limb movements, side-to-side head shaking, pelvic thrusting, eye closure during the event, preserved awareness during apparent bilateral motor activity, crying or emotional expression during events, rapid postictal reorientation without confusion, and recall of events that appeared to involve impaired consciousness. No single semiological feature is pathognomonic for psychogenic non-epileptic seizures, and diagnosis requires consideration of the overall clinical picture. Video E.EG monitoring remains the gold standard for diagnosis, demonstrating typical events in the absence of ictal epileptiform activity. However, it is important to recognize that surface EEG may not detect seizures arising from deep or mesial structures, and that frontal lobe seizures can have unusual semiology with minimal surface EEG changes. Clinical correlation and experienced interpretation are essential. Additionally, psychogenic non-epileptic seizures and epileptic seizures can coexist in the same patient, with studies suggesting that 10 to 30% of patients with psychogenic non-epileptic seizures also have epilepsy, necessitating careful characterization of all event types. Let me now cover some domain-specific assessment strategies. Functional gait disorders are common and can be highly disabling. The assessment relies on identification of gait patterns that are inconsistent with recognized neurological gait disorders and that demonstrate variability, distractibility, and incongruity. Characteristic features of functional gait include excessive slowness or hesitation not explained by weakness or ataxia, astasia-abasia with dramatic lurching and near falls without actual falling, improvement with distraction, or when the patient believes they are not being observed, knee buckling that does not result in falls, uneconomic postures that require more strength to maintain than normal walking, and sudden improvement with specific interventions such as walking backward or running. Observation of spontaneous mobility, such as transfers, reaching, or movement in the waiting room, often reveals capabilities that exceed those demonstrated during formal gait examination. This discrepancy reflects the influence of attention and self-monitoring on functional symptoms rather than deliberate deception. Video recording of gait examination and functional mobility can be valuable for documentation and for demonstrating inconsistencies to patients as part of the diagnostic explanation. Functional speech disorders include dysphonia, aphonia, dysarthria, and stuttering with functional etiology. Characteristic features include variability in speech quality across contexts, improvement with distraction or automatic speech tasks, inconsistency between conversational speech and formal testing, and incongruity with recognized neurological speech disorders. Functional aphonia often demonstrates preserved whispered speech and normal cough, indicating intact vocal cord function. Functional dysarthria may show inconsistent articulation errors, preserved automatic speech such as counting or reciting familiar phrases, and improvement during singing or emotional expression. Functional cognitive symptoms, sometimes termed functional cognitive disorder, present as subjective cognitive complaints, often involving memory, attention, and word finding, that are inconsistent with objective cognitive testing or that show patterns atypical for neurodegenerative or structural brain disease. Patients may report severe memory impairment but demonstrate intact performance on formal memory testing, or may show inconsistency between reported and observed functional abilities. The assessment of functional cognitive symptoms requires careful neuropsychological evaluation and should include attention to effort and performance validity testing. Now, regarding differential diagnosis considerations, the differential diagnosis for FND is broad and includes organic neurological diseases, other psychiatric conditions, and functional somatic syndromes. Accurate diagnosis requires systematic consideration of alternative explanations while recognizing that the presence of positive FND signs provides strong evidence for the diagnosis. Organic neurological conditions that may be confused with FND include stroke, multiple sclerosis, epilepsy, Parkinson disease and other movement disorders, myasthenia gravis, and peripheral neuropathies. Key distinguishing features include the presence of objective signs consistent with specific lesion locations, characteristic disease progression patterns, and supportive findings on neuroimaging, electrophysiology, or laboratory testing. However, it is essential to remember that FND can coexist with these conditions, and the identification of organic disease does not exclude functional overlay. Factitious disorder and malingering must be considered in the differential diagnosis but should not be assumed without specific evidence. Factitious disorder involves intentional production of symptoms for psychological reasons, typically to assume the sick role, while malingering involves symptom fabrication for external gains such as financial compensation or avoidance of responsibilities. Both are rare compared to FND, and the assumption that symptoms are deliberately produced can cause significant harm to patients and damage the therapeutic relationship. The diagnosis of factitious disorder or malingering requires positive evidence of intentional deception, not merely the absence of organic findings. Functional somatic syndromes, including fibromyalgia, irritable bowel syndrome, and chronic fatigue syndrome share features with FND and may co-occur. These conditions are characterized by somatic symptoms that are not fully explained by organic disease, significant functional impairment, and responsiveness to similar biopsychosocial treatment approaches. The relationship between FND and functional somatic syndromes is an area of active research, with evidence suggesting shared pathophysiological mechanisms involving altered central processing of sensory information. While the rule-in approach emphasizes positive diagnosis based on clinical signs, you must remain vigilant for red flags suggesting alternative or coexisting pathology. Red flags that warrant additional investigation include progressive symptoms without fluctuation or variability, symptoms that conform strictly to neuroanatomical patterns, acute onset with risk factors for vascular events, new onset seizures in older adults without prior history, evidence of structural lesions on neuroimaging, systemic symptoms such as fever, weight loss, or night sweats, and symptoms that are atypical for FND presentations. The presence of red flags does not exclude FND but should prompt appropriate investigation to evaluate for alternative diagnoses. Similarly, the absence of red flags and the presence of positive clinical signs provide strong support for FND diagnosis without the need for exhaustive testing. The goal is appropriate, targeted investigation guided by clinical reasoning rather than either reflexive extensive testing or premature diagnostic closure. Clinical decision-making becomes more complex when FND coexists with organic neurological disease. In these situations, careful assessment is required to determine which symptoms are attributable to each condition and to develop treatment plans that address both. Patients with epilepsy and comorbid psychogenic non-epileptic seizures require anti-seizure medications for their epilepsy and psychological interventions for their functional seizures. Patients with multiple sclerosis and functional overlay require disease-modifying therapy for their MS and rehabilitation approaches targeting functional symptoms. Multidisciplinary collaboration and clear communication among treating clinicians are essential in these complex cases. For rehabilitation and allied health professionals, competency in recognizing the clinical signs of FND serves several important functions. During initial evaluation, awareness of positive FND signs allows you to recognize when functional symptoms may be present, even in patients who have not yet received a formal diagnosis. This recognition can facilitate appropriate referral to neurology for diagnostic confirmation and can inform clinical reasoning about the expected response to different therapeutic approaches. During treatment, understanding the clinical features of FND supports the selection of intervention strategies that target the underlying mechanisms of functional symptoms. Physical therapy approaches that emphasize distraction, automatic movement, and redirection of attention are more effective for functional motor symptoms than approaches designed for weakness due to corticospinal tract damage. Occupational therapy interventions can be tailored to address the specific patterns of functional impairment observed during assessment. Speech therapy for functional voice disorders employs techniques that differ from those used for neurogenic dysarthria. Understanding the clinical signs also enables you to communicate more effectively with patients about their diagnosis and treatment. Patients benefit from explanations that reference the specific examination findings that support the diagnosis, demonstrating that the diagnosis is based on what the clinician found rather than on what was not found. This approach enhances diagnostic confidence, reduces stigma, and supports patient engagement in treatment. Now let's move into our third module on rehabilitation and multidisciplinary management, where we'll explore physical, occupational, and psychological interventions in depth. The management of functional neurological disorders requires a fundamentally different approach from that used for organic neurological conditions. While the symptoms may appear similar to those caused by stroke, multiple sclerosis, or Parkinson disease, the underlying mechanisms differ profoundly, and treatment strategies must be tailored accordingly. The pathophysiology of FND, involving abnormal brain network function, altered predictive processing, and dysregulated attention-motor coupling, demands interventions that target these specific mechanisms rather than compensating for structural damage or neurodegeneration. Contemporary evidence supports multidisciplinary rehabilitation as the cornerstone of FND management. This approach integrates physical therapy, occupational therapy, psychological interventions, and patient education within a coordinated framework that addresses the biological, psychological, and social dimensions of the disorder. For non-specialist clinicians working in rehabilitation settings, understanding the principles and evidence base for these interventions is essential for providing effective patient-centered care. Let's begin with the principles of physical therapy for functional neurological disorders. Physical therapy represents a primary treatment modality for patients with motor FND, including those with functional weakness, movement disorders, and gait disturbances. However, the therapeutic approach differs substantially from conventional neurorehabilitation used for patients with structural neurological damage. Understanding these distinctions is essential for physical therapists and other clinicians involved in motor rehabilitation of FND patients. Conventional neurorehabilitation for conditions such as stroke or traumatic brain injury focuses on compensating for lost function, strengthening weakened muscles, and promoting neuroplastic reorganization to recover motor capabilities that have been impaired by structural damage. These approaches assume that the motor pathways have been damaged and that recovery depends on either restoration of function through neural reorganization or compensation through alternative strategies. In FND, however, the motor pathways are structurally intact, and the impairment arises from abnormal functional processing rather than from damage to neural structures. Strengthening exercises for functional weakness are therefore unlikely to be effective and may inadvertently reinforce the illness model by implying that the muscles themselves are deficient. Similarly, compensatory strategies such as mobility aids or adaptive equipment, while sometimes necessary for safety, can perpetuate disability by reinforcing abnormal movement patterns and reducing opportunities for normal motor function. Physical therapy for FND instead targets the mechanisms that generate and maintain symptoms, including excessive self-focused attention, abnormal movement predictions, and maladaptive motor habits. The therapeutic goal is to restore normal, automatic movement by redirecting attention away from the affected body part and toward functional goals, thereby allowing intact motor pathways to operate without interference from dysfunctional top-down processing. The core strategies in physical therapy for motor FND include distraction, redirection of attention, promotion of automatic movement, graded motor retraining, and demonstration of normal function. These techniques exploit the observation that functional symptoms often improve when attention is directed away from the symptomatic movement and toward other tasks or goals. Distraction techniques involve engaging the patient in cognitive tasks, conversation, or motor activities with the unaffected limbs while simultaneously encouraging movement in the affected region. For example, a patient with functional leg weakness might be asked to perform rhythmic arm movements or to count backward while attempting to walk. The cognitive load reduces the capacity for excessive self-monitoring and allows more automatic motor control to emerge. Similarly, engaging patients in dual-task activities during gait training can reduce functional gait abnormalities by diverting attention from the act of walking. Novel motor tasks that bypass established abnormal movement patterns can facilitate normal function. Walking backward, walking with altered rhythm, or performing unfamiliar movement sequences may reveal preserved motor capabilities that are not apparent during forward walking or routine activities. These tasks engage motor planning processes in new ways and can demonstrate to both the patient and clinician that the underlying motor system is capable of normal function. Graded motor retraining begins with basic movement patterns and progressively advances to more complex functional activities. For patients with functional weakness, this might involve starting with simple weight shifting and sitting, progressing to standing weight shifts, then to stepping, and finally to walking. Each stage builds on demonstrated capabilities and gradually increases demands while maintaining the focus on automatic goal-directed movement rather than isolated muscle activation. The progression should be guided by the patient's response and should emphasize quality of movement over quantity. Demonstration of normal function during examination or treatment can be therapeutically valuable when incorporated appropriately. When a patient with functional weakness demonstrates normal strength during Hoover's sign testing or normal gait during backward walking, this information can be used educationally to reinforce the message that the motor system is intact and capable of normal function. This approach must be implemented with sensitivity and within the context of a supportive therapeutic relationship to avoid the impression that the patient is being caught or accused of faking symptoms. Now let's look at the evidence from randomized controlled trials for physical therapy and FND. The evidence base has expanded substantially in recent years, with several randomized controlled trials providing important data on efficacy and optimal treatment approaches. The Physio4-FMD trial represents the largest randomized controlled trial of physiotherapy for functional motor disorder conducted to date. This pragmatic multicenter Phase 3 trial was conducted across sites in England and Scotland. It randomized 355 adults with functional motor disorder to either specialist physiotherapy or treatment as usual, consisting of community-based neurological physiotherapy. The specialist physiotherapy intervention comprised 9 treatment sessions plus a follow-up session, delivered by physiotherapists who had received specific training in FND management. The treatment protocol emphasized education about FND, movement retraining using distraction and automatic movement strategies, and graded functional rehabilitation. The primary outcome was physical functioning as measured by the SF-36 Physical Functioning Subscale at 12 months. The adjusted mean difference between groups was 3.5 points, with a 95% confidence interval of -2.3 to 9.3, which did not reach statistical significance. However, secondary outcomes revealed important benefits. Significantly more participants in the specialist physiotherapy group self-rated their motor symptoms as improved compared to the control group, and specialist physiotherapy was associated with better scores on measures of mental health and subjective well-being. Both interventions were safe with no serious adverse events related to physiotherapy. The Physio4-FMD findings illustrate several important points about FND treatment research. First, both specialist and community-based physiotherapy produced improvements, suggesting that physiotherapy in general has value for FND patients. Second, the modest between-group difference on the primary outcome may reflect the fact that both groups received active treatment rather than indicating that specialist physiotherapy lacks benefit. Third, subjective improvement and mental health outcomes showed clearer benefits, highlighting the importance of patient-reported outcomes in FND research. Fourth, physiotherapy for FND is safe and well accepted by patients. Another important trial was conducted by Macias Garcia and colleagues, who compared combined physiotherapy and cognitive behavioral therapy to psychological support alone in adults with functional movement disorders. This study addressed the hypothesis that integrating physical and psychological treatments would produce greater benefits than psychological intervention alone. The combined intervention included structured physiotherapy sessions targeting motor symptoms alongside cognitive behavioral therapy, addressing psychological factors, illness beliefs, and self-management strategies. The primary outcomes were the SF-36 Physical Component Summary and Mental Component Summary scores, with higher scores indicating better quality of life. At 5 months of follow-up, the combined intervention group demonstrated significantly greater improvements in physical functioning and overall quality of life compared to the control group. These findings provide direct evidence for the superiority of integrated physical and psychological treatment over psychological support alone and support the rationale for multidisciplinary rehabilitation approaches. Now let's consider occupational therapy approaches. Occupational therapy plays an important but historically under-recognized role in the multidisciplinary management of FND. While physical therapy addresses motor impairments directly, occupational therapy focuses on functional participation in daily activities, addressing the impact of symptoms on meaningful occupations, and supporting patients in achieving their personal goals for independence and engagement. Emerging evidence suggests that many patients with FND experience difficulties with sensory processing that contribute to symptom generation and maintenance. Sensory modulation refers to the ability to regulate responses to sensory input, maintaining an optimal level of arousal and attention for effective functioning. Patients with FND may demonstrate sensory over-responsivity, seeking or avoidance patterns that influence their symptom experience and functional capabilities. Occupational therapists can assess sensory processing using validated instruments such as the Adolescent Adult Sensory Profile, which identifies patterns of sensory processing and provides guidance for intervention planning. Based on assessment findings, sensory modulation interventions may include environmental modifications to reduce sensory overload, sensory diet programs that provide structured sensory input to support regulation, and training in self-regulation strategies. These approaches address an often overlooked dimension of FND and can enhance the effectiveness of motor-focused interventions. The Canadian Occupational Performance Measure provides a framework for identifying patient-specific functional goals and monitoring progress. This client-centered assessment involves collaborative identification of activities that the patient needs to, wants to, or is expected to perform, followed by rating of performance and satisfaction in these areas. The measure ensures that treatment focuses on outcomes that are meaningful to the individual patient, rather than on generic functional benchmarks. Occupational therapy interventions for FND may include activity analysis and modification to support successful performance, graded engagement in meaningful activities, energy conservation and fatigue management strategies, and vocational rehabilitation to support return to work. The focus throughout is on enabling participation in valued life roles despite ongoing symptoms, while simultaneously working towards symptom reduction through engagement in normal activities. Psychological interventions are recommended across all FND symptom domains and represent an essential component of comprehensive management. Cognitive behavioral therapy is the most extensively studied psychological intervention for FND, with a substantial evidence base supporting its efficacy. Other psychological approaches, including psychodynamic therapy and integrated multimodal treatments, may benefit select patients, though the evidence base is less robust. Cognitive behavioral therapy for FND has been adapted from generic CBT protocols to address the specific features and mechanisms of functional neurological symptoms. The therapy typically incorporates several core components that target different aspects of the disorder. Psychoeducation forms the foundation of CBT for FND, helping patients understand the nature of their condition, the relationship between brain function and symptoms, and the rationale for treatment. Effective psychoeducation validates the reality of symptoms while explaining their functional basis, reduces stigma and self-blame, and provides a framework for understanding how psychological interventions can influence neurological symptoms. This educational component is often continued throughout treatment as understanding deepens. Cognitive restructuring addresses maladaptive thoughts and beliefs that may contribute to symptom maintenance. Patients with FND often hold unhelpful beliefs about their symptoms, their body, their ability to recover, and the meaning of physical sensations. CBT helps patients identify these cognitions, evaluate their accuracy, and develop more adaptive alternative perspectives. For example, a patient who interprets any physical sensation as evidence of serious illness may learn to recognize this catastrophizing pattern and develop more balanced interpretations. Behavioral interventions target patterns of activity avoidance, excessive rest, and safety behaviors that can perpetuate disability. Many patients with FND restrict their activities in response to symptoms, leading to deconditioning, social isolation, and reinforcement of the sick role. CBT employs graded behavioral activation to gradually increase engagement in avoided activities, challenging the expectation that activity will worsen symptoms and demonstrating through direct experience that normal function is possible. Trigger identification and management help patients recognize factors that precipitate or exacerbate symptoms. These may include specific situations, emotional states, physical sensations, or interpersonal interactions. Once triggers are identified, patients learn strategies for managing these situations, including relaxation techniques, cognitive coping strategies, and behavioral approaches to reduce vulnerability. Self-management training equips patients with skills and strategies for independent symptom management after treatment concludes. This includes recognition of early warning signs, implementation of coping strategies, relapse prevention planning, and maintenance of gains achieved during treatment. The goal is to empower patients as active agents in their own recovery rather than passive recipients of treatment. Systematic reviews and meta-analyses have examined the evidence for psychological therapies in FND. An umbrella review synthesized findings across multiple systematic reviews and meta-analyses, concluding that CBT produces medium-sized benefits for physical symptoms, mental health, and functional outcomes when delivered within multidisciplinary treatment contexts. The evidence supports CBT as an effective intervention, though the quality of individual studies varies and further high-quality research is needed. A systematic review of psychotherapy for adults with FND examined randomized controlled trials and controlled studies of various psychological interventions. The review found evidence supporting the efficacy of CBT, with particularly strong evidence for CBT in functional seizures. The authors noted that effect sizes were generally in the medium range and that benefits were observed across multiple outcome domains including seizure frequency, psychological distress, and quality of life. The review also identified a need for larger, methodologically rigorous trials to strengthen the evidence base. Psychodynamic therapy and psychodynamically informed interventions represent an alternative or adjunctive approach for some patients with FND. These therapies focus on exploring unconscious conflicts, developmental experiences, and relational patterns that may contribute to symptom development and maintenance. Psychodynamic interpersonal therapy has shown promise in trials for functional seizures, though the evidence base is smaller than that for CBT. Psychodynamic approaches may be particularly relevant for patients with significant trauma histories or interpersonal difficulties. Multimodal psychotherapy, integrating elements from different therapeutic traditions, including cognitive, behavioral, psychodynamic, and systemic approaches, may offer benefits for patients with complex presentations. The flexible integration of techniques allows treatment to be tailored to individual patient needs and may address dimensions not fully captured by standardized CBT protocols. However, the evidence base for multimodal approaches is limited, and treatment outcomes may depend heavily on therapist expertise and the quality of the therapeutic relationship. Now let's discuss multidisciplinary program structures. The integration of physical therapy, occupational therapy, psychological intervention, and patient education within coordinated multidisciplinary programs represents the optimal approach for FND management. Such programs ensure consistent messaging across disciplines, facilitate communication among treating clinicians, and address the multiple dimensions of the disorder simultaneously. Outpatient multidisciplinary programs for FND typically involve regular attendance at a treatment center for structured individual and group interventions over a defined period. An exemplary model is an 8-week outpatient program that combines individual physiotherapy, group physiotherapy, individual CBT, and psychoeducation. Patients attend the program multiple days per week and engage in a structured curriculum that progresses through education, skill acquisition, and application phases. Outcome data from such programs demonstrate significant improvements in anxiety, depression, functional impairment, and mobility measures from pre-treatment to post-treatment, with sustained benefits at 3-month follow-up. Specifically, anxiety and depression scores show statistically significant reductions, indicating improvement in psychiatric symptoms. Timed mobility tests and other mobility measures demonstrate functional gains, and patient-reported outcomes reflect improved quality of life and reduced disability. Similar results have been reported from other outpatient programs. One study described outcomes from a 5-week individualized multidisciplinary day patient program that included physiotherapy, occupational therapy, psychology, and nursing input. The program produced significant improvements in physical and mental health outcomes, with benefits maintained at follow-up. The individualized nature of the program, with treatment intensity and content tailored to patient needs, was identified as a strength. For patients with severe disability who are unable to participate in outpatient programs or who require more intensive intervention, inpatient rehabilitation may be appropriate. Inpatient programs provide a structured environment with daily multidisciplinary treatment, intensive monitoring, and removal from potentially perpetuating factors in the home environment. The concentrated nature of inpatient treatment can accelerate progress and may be particularly valuable for patients who have not responded to outpatient approaches. A prospective study examined outcomes from an intensive inpatient multidisciplinary program for patients with FND. The program included daily physiotherapy, occupational therapy, psychotherapy, and nursing care, with treatment individualized to patient presentation. Significant improvements were observed in motor function, psychological symptoms, and quality of life, with the majority of patients demonstrating clinically meaningful gains. The study identified factors associated with better outcomes, including shorter symptom duration and higher baseline function, providing guidance for patient selection and prognosis. Effective multidisciplinary programs share several design features that contribute to their success. First, all team members work from a shared understanding of FND and communicate consistent messages to patients about the nature of the condition and the rationale for treatment. Contradictory messages from different clinicians can undermine patient confidence in treatment engagement. Second, programs incorporate structured psychoeducation that addresses patient and family questions, reduces stigma, and promotes self-management. Third, treatment is goal-directed and patient-centered, with outcomes defined by meaningful functional improvements rather than abstract clinical measures. Fourth, programs include explicit attention to relapse prevention and maintenance of gains, preparing patients for independent management after discharge. Regarding pharmacological considerations, pharmacological treatment plays a limited but important role in FND management. Medications are not effective for core FND symptoms and should not be used as primary treatment for functional weakness, movement disorders, or seizures. However, pharmacotherapy may be valuable for treating comorbid psychiatric conditions that are common in FND patients and that can impair treatment engagement and outcomes. Depression and anxiety disorders co-occur with FND at high rates, and untreated psychiatric comorbidity is associated with worse prognosis. Selective serotonin reuptake inhibitors and serotonin norepinephrine reuptake inhibitors represent first-line pharmacological treatments for depression and anxiety in FND patients, following standard prescribing guidelines. These medications can reduce psychological distress, improve mood and anxiety symptoms, and may indirectly benefit FND symptoms by reducing emotional arousal and improving treatment engagement. Certain medication classes should be avoided or used with caution in FND patients. Benzodiazepines, while sometimes prescribed for anxiety, can worsen functional symptoms, impair cognition, and carry risks of dependence. Their sedating effects may reinforce avoidance behaviors and reduce engagement in rehabilitative activities. Similarly, opioid medications for comorbid pain conditions can perpetuate disability, worsen fatigue, and create additional problems related to dependence and tolerance. The general principle is that medications should not be prescribed with the expectation of treating core FND symptoms, and that sedating or dependency-producing medications should be minimized. Now let's move into our fourth module, which addresses long-term management, prognosis, and outcome measurement. The trajectory of functional neurological disorders extends far beyond the initial diagnosis and acute treatment phase. While multidisciplinary rehabilitation can produce significant improvements in motor function, psychological well-being, and quality of life, maintaining these gains over the long term presents distinct challenges. Many patients experience fluctuating symptoms, periodic exacerbations, and ongoing functional limitations that require sustained support and management. Understanding the principles of long-term management, the factors that influence prognosis, and the methods for measuring outcomes is essential for clinicians who provide continuing care to patients with FND. For non-specialist clinicians in rehabilitation and allied health settings, the long-term perspective is particularly relevant. You often maintain therapeutic relationships with patients over extended periods and may be the primary point of contact when symptoms recur or new challenges emerge. Let's begin by discussing the communication of diagnosis as a therapeutic intervention. The manner in which the diagnosis of FND is communicated to patients represents one of the most important determinants of long-term outcome. Far from being a simple informational exchange, the diagnostic conversation is itself a therapeutic intervention that can either facilitate recovery or perpetuate disability. Research consistently demonstrates that patients who understand and accept their diagnosis have better outcomes than those who remain confused, skeptical, or feel dismissed by their clinicians. Effective communication of an FND diagnosis requires clarity, transparency, empathy, and a focus on what the diagnosis means for the patient's understanding and treatment rather than what it excludes. The conversation should emphasize several key messages that help patients make sense of their experience and engage productively with treatment. First, you should clearly name the diagnosis, using terminology that the patient can understand and research independently. Terms such as functional neurological disorder, functional movement disorder, or functional seizures are preferred over older terminology that carries stigmatizing connotations. You should explain that this is a recognized medical condition with an established evidence base for diagnosis and treatment, not a label applied when doctors cannot find an explanation. Second, the explanation should validate the reality of symptoms. Patients need to understand that their symptoms are genuine, involuntary, and not imagined or fabricated. You can explain that FND involves real changes in how the brain controls movement or processes sensation, even though the underlying neural structures are intact. Analogies can be helpful, such as comparing the brain to a computer with a software problem rather than hardware damage, or describing the condition as involving miscommunication between different brain regions. Third, you should explain the basis for the diagnosis in positive terms, referencing the specific clinical signs that were observed during examination. Rather than saying we ruled out stroke and multiple sclerosis, you might say we found specific signs during your examination that tell us this is a functional disorder, and then describe Hoover's sign, tremor entrainment, or other relevant findings. This approach demonstrates that the diagnosis rests on positive evidence rather than on the absence of findings, increasing patient confidence in its validity. Fourth, the conversation should emphasize the potential for improvement and recovery. While avoiding unrealistic promises, clinicians can honestly convey that many patients with FND improve significantly with appropriate treatment, that the intact underlying neural pathways provide a foundation for recovery, and that effective treatments are available. This message of hope is essential for engaging patients in the often challenging work of rehabilitation. Fifth, you should provide a clear rationale for the recommended treatment approach, explaining how physical therapy, psychological intervention, and self-management strategies address the mechanisms of FND. Patients are more likely to engage with treatments that make sense to them than with interventions prescribed without explanation. The biopsychosocial framework provides a useful structure for explaining how biological, psychological, and social factors interact in FND and how treatment addresses each domain. Patients receiving an FND diagnosis often have questions and concerns that require sensitive and informed responses. Many patients worry that the diagnosis means their symptoms are all in their head or that doctors think they are faking. You should directly address these concerns, explaining that FND is a neurological condition involving abnormal brain function, that symptoms are involuntary, and that the diagnosis does not imply psychiatric causation or deliberate symptom production. Some patients express frustration that they underwent extensive testing only to receive a diagnosis of FND, feeling that the workup was a waste of time or that doctors failed to find the real problem. You can reframe this experience by explaining that a thorough evaluation was necessary to make the diagnosis with confidence and that the testing provided important information supporting the functional nature of symptoms. The diagnosis of FND is not a failure to find disease, but rather a positive identification of a specific condition. Patients may also question whether their symptoms could represent an early or atypical presentation of a progressive neurological disease that has not yet become apparent. While acknowledging that medical understanding is always evolving, you can explain that the positive clinical signs of FND are highly specific and reliably distinguish functional from organic symptoms. Patients should be reassured that they can return for reevaluation if new symptoms develop, but that repeated testing in the absence of new clinical findings is unlikely to be helpful and may reinforce illness anxiety. Family members and caregivers play important roles in long-term FND management and should be included in diagnostic communication when appropriate and with patient consent. Family members often share patients' confusion about the diagnosis and may harbor misconceptions that undermine treatment. Including them in educational discussions ensures consistent messaging, helps them understand how to support the patient's recovery, and prepares them to respond appropriately to symptom fluctuations. Family involvement can also address unhelpful dynamics that may perpetuate disability. Well-meaning family members sometimes reinforce the sick role by doing too much for the patient, expressing excessive concern about activity, or inadvertently rewarding symptom behaviors with attention and care. Education about FND and the importance of encouraging normal activity despite symptoms can help families adopt more therapeutic responses. Conversely, family members who are skeptical or dismissive of the diagnosis may undermine the patient's confidence and treatment engagement. Targeted education may help these individuals understand the legitimacy of the condition. Now let's discuss relapse prevention and ongoing support. Maintaining improvements achieved during acute treatment requires deliberate attention to relapse prevention and ongoing support. FND is often a chronic or relapsing condition, and patients benefit from strategies that help them manage symptom fluctuations, recognize early warning signs, and respond effectively to exacerbations. Recovery from FND is typically not linear, and patients should be prepared for fluctuations in symptoms over time. Unlike recovery from acute conditions such as fractures or infections, improvement in FND often involves periods of progress interspersed with setbacks, plateaus, and symptom variations. Patients who expect steady, continuous improvement may become discouraged by normal fluctuations and may interpret temporary worsening as evidence that treatment has failed or that their condition is deteriorating. Education about the expected trajectory of recovery helps patients maintain perspective and continue with management strategies during difficult periods. You should help patients understand that symptom fluctuations often relate to identifiable factors such as stress, fatigue, illness, or changes in routine. Recognizing these associations empowers patients to anticipate and manage periods of increased vulnerability. At the same time, you should avoid implying that patients are responsible for causing their symptoms, or that symptom worsening represents personal failure. The goal is to promote agency and self-management while maintaining compassion and avoiding blame. Development of individualized self-management plans is a cornerstone of relapse prevention. These plans, typically created collaboratively between the patient and treatment team near the end of intensive treatment, document the strategies and skills that the patient has found helpful and provide guidance for managing symptom exacerbations independently. Effective self-management plans typically include identification of personal triggers and warning signs that precede symptom worsening, specific strategies for managing each type of symptom, guidance on when and how to implement relaxation, distraction, or motor retraining techniques, instructions for graduated return to normal activity following exacerbations, criteria for when to seek professional help, and contact information for treatment providers. The plan should be written in language that is meaningful to the patient and should be reviewed periodically to incorporate new learning and adjust to changing circumstances. Avoidance behaviors represent a common barrier to sustained recovery. Patients may avoid activities, situations, or environments that they associate with symptom onset or worsening, leading to progressive restriction of life participation and reinforcement of disability. While avoidance provides short-term relief from anxiety about symptoms, it prevents exposure to experiences that could disconfirm catastrophic expectations and demonstrate the capacity for normal function. Long-term management should include ongoing attention to avoidance patterns and support for gradual re-engagement with avoided activities. This process often requires courage on the part of patients and patience on the part of clinicians, as progress may be slow and setbacks common. The principles of graded exposure used in anxiety treatment apply here, with patients systematically approaching avoided situations in a hierarchical fashion while applying coping strategies learned during treatment. Success in previously avoided activities builds confidence and provides evidence against illness beliefs that support disability. While the goal of FND treatment is to equip patients with skills for independent management, many patients benefit from ongoing professional support at reduced intensity. Follow-up appointments provide opportunities to review progress, troubleshoot difficulties, adjust management strategies, and address new challenges. The frequency of follow-up should be individualized based on symptom severity, stability, and patient preference, with more frequent contact during periods of instability and less frequent contact as patients demonstrate sustained improvement. The structure of ongoing support varies depending on available resources and patient needs. Some patients benefit from periodic check-ins with their primary care provider, who has been educated about FND management. Others may require ongoing involvement of specialists such as neurologists, psychiatrists, or psychologists. Allied health professionals, including physical therapists and occupational therapists, may provide maintenance therapy or episodic treatment during exacerbations. Multidisciplinary coordination remains important even during the maintenance phase to ensure consistent messaging and comprehensive care. Now let's examine prognostic factors and treatment response. The prognosis for FND is variable, and understanding the factors that influence outcome helps clinicians counsel patients appropriately, allocate treatment resources effectively, and identify patients who may require modified or intensified approaches. Several factors are consistently associated with more favorable outcomes in FND. Shorter symptom duration at the time of diagnosis and treatment initiation predicts better response, highlighting the importance of early recognition and prompt referral to appropriate care. Patients with symptoms present for months rather than years are more likely to achieve substantial improvement than those with long-standing, entrenched presentations. Understanding and acceptance of the diagnosis is strongly associated with treatment engagement and positive outcomes. Patients who comprehend the nature of FND, accept the validity of the diagnosis, and engage actively with the treatment rationale are more likely to benefit from rehabilitation and psychological interventions. Conversely, patients who reject the diagnosis, continue to seek alternative explanations, or remain convinced that an undetected organic disease is responsible, tend to have poorer outcomes regardless of the treatments offered. Early access to evidence-based treatment predicts better outcomes. Patients who receive multidisciplinary rehabilitation and psychological therapy soon after diagnosis fare better than those who experience delays in accessing appropriate care. This finding underscores the importance of developing accessible FND treatment services and reducing barriers to referral. Workforce participation at baseline or return to work during treatment is associated with better long-term outcomes. Employment provides structure, social connection, financial security, and a sense of purpose that support overall well-being and recovery. Maintaining work despite symptoms or gradually returning to work during treatment should be encouraged when feasible, and vocational rehabilitation should be considered for patients at risk of work loss. On the other hand, several factors are associated with poorer outcomes. Chronic, severe, and long-standing symptoms are associated with reduced likelihood of improvement. Patients with symptoms persisting for many years often demonstrate limited response to treatment, possibly reflecting entrenched maladaptive patterns, secondary changes in brain function, and accumulated disability. While treatment should not be withheld from these patients, expectations should be calibrated appropriately, and goals may focus on reducing disability and improving quality of life rather than achieving complete symptom resolution. Older age, particularly in men, has been associated with less favorable outcomes in some studies, though age alone should not preclude treatment. Older patients may have more fixed symptom patterns, greater accumulated disability, and more comorbid conditions that complicate management. They may also face different social circumstances, including retirement and reduced social networks, that affect recovery context. Significant untreated psychiatric comorbidity impairs treatment response. Depression, anxiety, post-traumatic stress disorder, and personality disorders are common in FND and, when unaddressed, interfere with rehabilitation engagement and perpetuate symptom-maintaining factors. Comprehensive management requires identification and treatment of psychiatric comorbidities alongside FND-specific interventions. Patients with severe psychiatric conditions may require stabilization before they can benefit from FND rehabilitation. Poor understanding or acceptance of the diagnosis predicts treatment failure. Patients who do not believe the diagnosis, who continue to pursue alternative explanations, or who feel their symptoms have been dismissed, are unlikely to engage meaningfully with recommended treatments. Addressing diagnostic uncertainty through repeated education, responding to patient concerns, and building therapeutic alliance are essential before expecting treatment gains. High levels of chronic pain, fatigue, and iatrogenic harm complicate treatment and are associated with worse outcomes. Patients who have undergone unnecessary surgeries, who take multiple medications with sedating or dependency-producing effects, or who have developed secondary complications from prolonged immobility, face additional barriers to recovery. Prevention of iatrogenic harm through early accurate diagnosis is preferable to attempting to reverse established complications. A consistent finding across FND treatment studies is substantial heterogeneity in treatment response. Some patients achieve dramatic and sustained improvement, while others show modest gains, and still others demonstrate minimal response despite receiving evidence-based treatment. This heterogeneity reflects the diverse pathways leading to FND, individual differences in neurobiological and psychological factors, and varying social contexts that influence recovery. Current research cannot reliably predict which individual patients will respond to which specific treatments. This limitation highlights the need for individualized treatment planning, ongoing monitoring of response, and willingness to modify approaches when initial strategies prove ineffective. It also underscores the importance of continued research to identify predictors of treatment response and to develop novel interventions for patients who do not benefit from current approaches. Now let's turn to outcome measurement and quality of life assessment. Systematic measurement of outcomes is essential for monitoring treatment response, documenting progress, identifying patients who require modified approaches, and contributing to the evidence base for FND treatment. Contemporary practice emphasizes patient-centered outcome measurement that captures the domains most relevant to patients' lived experience and functional goals. Patient-reported outcome measures assess aspects of health status, functional ability, and quality of life from the patient's perspective. These instruments provide essential information that cannot be obtained from clinical examination alone and capture the impact of FND on dimensions that matter most to patients. The SF-36 and its shorter variant, the SF-12, are widely used generic health-related quality of life instruments that assess physical functioning, role limitations due to physical and emotional problems, bodily pain, general health, vitality, social functioning, and mental health. The SF-36 Physical Component Summary and Mental Component Summary scores provide overall indices of physical and mental health status that can be compared to population norms and tracked over time. The SF-36 has been used as a primary outcome measure in major FND treatment trials, including the Physio-4 FMD trial and the Combined Physiotherapy CBT trial. The EQ-5D5L is another widely used generic quality of life instrument that assesses 5 dimensions: mobility, self-care, usual activities, pain and discomfort, and anxiety and depression. Each dimension is rated on a 5-level severity scale, and responses can be converted to a single utility index suitable for health economic analyses. The EQ-5D also includes a visual analog scale on which patients rate their overall health from 0 to 100. The instrument's brevity makes it practical for routine clinical use and repeated administration. The Work and Social Adjustment Scale is a brief measure of functional impairment that assesses the impact of symptoms on work, home management, social leisure activities, private leisure activities, and close relationships. Each domain is rated on a scale from 0 to 8, with higher scores indicating greater impairment. The scale provides a quick assessment of disability that is sensitive to change and relevant across FND subtypes. Given the high prevalence of psychiatric comorbidity in FND and its impact on outcomes, assessment of mental health status is an essential component of outcome measurement. Standardized instruments allow systematic evaluation of depression, anxiety, and other psychiatric symptoms. The Beck Depression Inventory 2 is a 21-item self-report measure that assesses the severity of depressive symptoms over the preceding 2 weeks. Items address cognitive, affective, and somatic symptoms of depression, with total scores categorized into minimal, mild, moderate, and severe depression ranges. This instrument has been extensively validated and is widely used in FND treatment studies and clinical practice. The Beck Anxiety Inventory is a 21-item self-report measure that assesses the severity of anxiety symptoms, with particular emphasis on somatic manifestations of anxiety. It helps distinguish anxiety from depression and is useful for monitoring response to treatment in patients with comorbid anxiety disorders. Clinician-rated measures provide complementary information based on clinical observation and judgment. The Clinical Global Impression Scale includes 2 components: the CGI Severity Scale, which rates the current severity of illness on a 7-point scale from normal to extremely ill, and the CGI Improvement Scale, which rates change from baseline on a 7-point scale from very much improved to very much worse. These simple global ratings capture overall clinical status and change in a format that is practical for routine use. For patients with motor FND, objective assessment of physical function provides important information that complements subjective reports. Standardized physical performance measures allow quantification of mobility and balance that can be tracked over time. The timed up-and-go test measures the time required for a patient to rise from a chair, walk 3 meters, turn, return to the chair, and sit down. The test provides a practical assessment of functional mobility that correlates with fall risk and independence in daily activities. It is sensitive to change and can be administered quickly in clinical settings. The 10-meter walk test assesses walking speed over a standardized distance, providing an objective measure of gait function. Walking speed is associated with overall functional status and can be compared to age-adjusted norms. The test can be administered at comfortable or maximum pace depending on the assessment goal. The Berg Balance Scale is a 14-item performance measure that assesses balance during various functional tasks, including standing, transferring, reaching, and turning. Each item is scored from 0 to 4 based on the ability to perform the task safely and independently. The scale provides detailed information about balance function and is useful for identifying specific deficits and monitoring response to balance-focused interventions. A significant challenge in FND research and clinical practice has been the lack of standardized outcome measures, which limits comparability across studies and complicates evidence synthesis. The FND Core Outcome Measure Initiative, known as FND-COM, has been working to address this gap by developing consensus recommendations for outcome measurement in FND research and clinical practice. The initiative involves input from patients, caregivers, and healthcare professionals to ensure that recommended measures capture the domains most important to all stakeholders. The FND-COM process has identified core domains that should be assessed in FND outcome measurement, including symptom severity, mental health, quality of life, and functional ability. The initiative is expected to produce recommendations for specific instruments that should be used across studies, facilitating comparison of results and enabling pooled analyses. Adoption of standardized measures in clinical practice would similarly improve consistency and enable benchmarking of outcomes across treatment settings. Let's now move into our fifth module, which covers implementation, emerging therapies, and professional considerations. The preceding modules have established that functional neurological disorders are common, disabling conditions for which effective evidence-based treatments exist. However, a significant gap persists between the availability of effective interventions and their implementation in routine clinical practice. Many patients with FND struggle to access appropriate care, encounter clinicians unfamiliar with contemporary management approaches, and face systemic barriers that impede their recovery. Bridging this implementation gap requires understanding the obstacles to effective care delivery, developing strategies to overcome these barriers, and ensuring that healthcare professionals across disciplines are equipped with the knowledge and skills necessary for competent FND management. Let's begin by examining the barriers to effective multidisciplinary care. The implementation of evidence-based multidisciplinary care for FND faces numerous barriers operating at the provider, patient, system, and societal levels. At the provider level, lack of education and expertise represents one of the most significant barriers. Many healthcare professionals receive minimal training in FND during their foundational education, and misconceptions about the nature of these conditions remain prevalent. Clinicians may view FND as primarily psychiatric, may doubt the genuineness of symptoms, or may feel uncomfortable managing conditions that do not fit neatly into traditional biomedical frameworks. These knowledge gaps and attitudinal barriers result in delayed diagnosis, inappropriate treatment, and communication that undermines patient confidence and engagement. Even among clinicians who recognize FND as a legitimate condition, many lack familiarity with the specific assessment techniques and treatment approaches that are effective for these patients. Physical therapists may apply conventional neurorehabilitation approaches that are ineffective or counterproductive for functional motor symptoms. Psychologists may use generic therapy protocols without the disorder-specific adaptations that optimize outcomes. The specialized knowledge required for effective FND management is not widely disseminated, limiting the pool of clinicians capable of providing appropriate care. At the system level, poor care coordination represents a pervasive barrier. FND requires integrated multidisciplinary management, yet healthcare systems are often organized around single specialty silos that impede collaboration. Patients may see neurologists, psychiatrists, physical therapists, and psychologists in separate settings with minimal communication among providers. Inconsistent messaging across providers can confuse patients and undermine treatment. The absence of clear care pathways and referral networks leaves patients and referring clinicians uncertain about where to access appropriate services. Limited access to specialized services affects many patients, particularly those in rural areas or regions without academic medical centers. Dedicated FND treatment programs remain relatively rare, and waiting times for available services may be lengthy. The geographic concentration of expertise creates inequities in access, with patients in underserved areas facing substantial barriers to obtaining evidence-based care. Telemedicine has potential to address some access barriers but is not universally available or reimbursed. Lack of sustainable funding threatens the viability of FND treatment services. Multidisciplinary programs require investment in personnel, training, and infrastructure that may be difficult to justify within constrained healthcare budgets. The complexity of FND and the time-intensive nature of effective treatment are often poorly captured by reimbursement models designed around acute, single-condition care. Programs may struggle to demonstrate value in terms recognized by healthcare administrators and payers, leading to inadequate resource allocation. At the patient level, stigma and disengagement create additional barriers. The historical legacy of dismissive treatment, diagnostic invalidation, and suggestions that symptoms are fabricated has left many patients with FND distrustful of healthcare providers. Patients may be reluctant to accept a diagnosis they perceive as delegitimizing, or may resist referral to psychological services that they associate with denial of their physical symptoms. Building trust and engagement with these patients requires time, skill, and consistent positive experiences that many healthcare settings struggle to provide. The heterogeneity of FND presentations complicates standardized treatment delivery. Patients present with diverse combinations of motor, sensory, seizure, and cognitive symptoms, varying levels of disability, different psychiatric comorbidities, and unique psychosocial contexts. Treatment approaches effective for one patient may be less suitable for another, requiring individualization that is resource-intensive and requires clinical expertise. This heterogeneity also complicates research, making it difficult to identify which treatments work best for which patients. At the research and measurement level, lack of standardized outcome measures has historically impeded both research and clinical quality improvement in FND. Different studies have used different instruments to assess treatment effects, limiting comparability and meta-analytic synthesis. In clinical settings, the absence of consensus on outcome measurement makes it difficult to track patient progress systematically, evaluate service quality, and demonstrate value to administrators and payers. The FNDCom initiative addresses this gap, but widespread adoption of standardized measures remains incomplete. Now let's discuss strategies for overcoming these implementation barriers. Addressing the barriers to effective FND care requires coordinated action across multiple domains, including professional education, service organization, policy advocacy, and patient engagement. Expanding professional education about FND is essential for increasing the workforce capable of providing effective care. Education initiatives should target multiple audiences, including medical students, neurology and psychiatry trainees, allied health students, and practicing clinicians across disciplines. Content should address the nature of FND as a genuine neurological condition, positive diagnostic approaches, evidence-based treatment principles, and appropriate communication strategies. For physical therapists, occupational therapists, and other allied health professionals, education should integrate understanding of FND pathophysiology with discipline-specific treatment techniques. Training should emphasize the differences between FND rehabilitation and conventional neurorehabilitation, the use of distraction and automatic movement strategies, sensory modulation approaches, and the integration of physical and psychological interventions. Hands-on clinical training, case-based learning, and mentorship from experienced clinicians enhance skill development beyond what didactic education alone can achieve. Continuing professional development programs can reach practicing clinicians who did not receive adequate FND training in their foundational education. Workshops, conferences, online modules, and clinical placements at specialized centers provide opportunities for skill acquisition. Professional organizations can promote FND education through their educational programming and competency frameworks. Developing coordinated care pathways and integrated service models addresses the fragmentation that impedes effective FND management. Clear referral networks that link primary care, neurology, psychiatry, and rehabilitation services facilitate timely access to appropriate care. Designated care coordinators, or case managers, can help patients navigate complex healthcare systems and ensure continuity across providers and settings. Stepped care models offer a framework for matching treatment intensity to patient needs while optimizing resource utilization. In a stepped care approach, all patients receive foundational interventions such as diagnostic communication and psychoeducation, with progression to more intensive treatments based on response and complexity. Patients with mild symptoms and good prognostic features may improve with brief intervention, while those with severe or treatment-resistant presentations receive intensive multidisciplinary care. This approach reserves specialized resources for patients who most need them, while ensuring universal access to basic evidence-based care. Dedicated FND clinics provide focused expertise and coordinated care within a single setting. These clinics typically involve neurologists, psychiatrists, psychologists, physical therapists, and other specialists working collaboratively with shared treatment philosophy and regular interdisciplinary communication. Patients benefit from consistent messaging, efficient care coordination, and access to the full range of evidence-based treatments. The development of additional dedicated programs in diverse geographic settings would expand access for currently underserved populations. Evidence supports the value of transdisciplinary ambulatory care models in improving outcomes and reducing healthcare utilization. A retrospective pre-post intervention service evaluation examined the impact of implementing an evidence-based ambulatory FND care model. The study found that the transdisciplinary approach was associated with significant reductions in emergency department presentations, suggesting that comprehensive outpatient management can avert acute care utilization that is both costly and often unhelpful for FND patients. These findings support investment in ambulatory FND programs as both clinically effective and potentially cost-saving. Advocacy for sustainable funding requires demonstrating the value of FND services to healthcare administrators, payers, and policymakers. This involves documenting patient outcomes, tracking healthcare utilization before and after treatment, and articulating the costs of inadequate care, including emergency department visits, hospitalizations, unnecessary investigations, and lost productivity. Engaging patient advocacy organizations amplifies the voice of those affected by FND and builds political will for resource allocation. Collaboration between clinical programs, researchers, and advocates can generate the evidence and visibility necessary to secure ongoing support. Now let's explore emerging therapies and novel approaches. While established evidence-based treatments, including multidisciplinary rehabilitation, cognitive behavioral therapy, and physical therapy, benefit many patients with FND, a substantial proportion experience incomplete response or treatment-refractory symptoms. This has prompted investigation of novel therapeutic approaches that may offer additional benefit for these patients. Emerging therapies for FND include neuromodulation techniques, novel psychotherapeutic approaches, and integrated treatment models that combine elements from multiple therapeutic traditions. Neuromodulation refers to techniques that use electrical or magnetic stimulation to alter neural activity. These approaches have shown promise in various neurological and psychiatric conditions and are being investigated for potential benefit in FND. Transcranial magnetic stimulation, which uses magnetic fields to induce electrical currents in specific brain regions, has been explored as an adjunctive treatment for functional motor symptoms. The rationale is that targeted stimulation of motor cortex may help normalize the abnormal brain network activity that underlies FND symptoms. Early studies have suggested potential benefit, though methodological limitations and small sample sizes preclude definitive conclusions. Larger, sham-controlled trials are needed to establish efficacy and identify which patients may benefit most from this approach. Eye movement desensitization and reprocessing therapy, known as EMDR, is an established treatment for post-traumatic stress disorder that has generated interest as a potential intervention for FND, particularly given the high prevalence of trauma in this population. EMDR involves recalling distressing memories while simultaneously engaging in bilateral stimulation, typically eye movements, which is thought to facilitate processing and integration of traumatic experiences. The rationale for applying EMDR to FND relates to the frequent association between trauma and functional neurological symptoms, with the hypothesis that processing unresolved traumatic memories may reduce symptom-maintaining psychological factors. The MODIFY trial is an ongoing randomized controlled trial evaluating EMDR for patients with functional seizures, representing one of the most rigorous investigations of this approach in FND to date. The study compares EMDR to treatment as usual and will provide important evidence regarding the efficacy of this approach for functional seizures specifically. However, preliminary findings reported from a preceding pilot study indicated that outcomes did not conclusively demonstrate superiority of EMDR over standard medical care. These results highlight the need for caution when extrapolating from trauma treatment literature to FND populations and underscore the importance of rigorous trial evidence before adopting novel interventions as routine clinical practice. Neurofeedback involves providing patients with real-time information about their brain activity, typically measured using electroencephalography, and training them to modulate this activity through operant conditioning. The approach has been explored for various conditions involving abnormal brain function and has generated interest in FND. Theoretical rationale for neurofeedback in FND relates to the demonstrated alterations in brain network connectivity and emotional motor coupling in these patients. If patients can learn to modulate relevant brain activity, this might translate to improved control over functional symptoms. However, evidence for neurofeedback in FND remains very limited, with only small case series and uncontrolled studies available. Controlled trials are needed before this approach can be considered evidence-based. Acceptance and commitment therapy, known as ACT, represents an alternative or adjunctive psychological approach that may benefit some FND patients. Unlike traditional CBT, which emphasizes changing thought content, ACT focuses on changing the relationship to thoughts and feelings, promoting acceptance of difficult internal experiences while committing to valued behavioral actions. The approach may be particularly relevant for FND patients who have not responded to CBT or who struggle with the cognitive restructuring components of traditional therapy. Mindfulness-based interventions, which train attention and awareness to present moment experience with a non-judgmental attitude, have been investigated for various functional and somatic symptom conditions. Mindfulness may help FND patients by reducing the excessive self-focused attention that perpetuates symptoms, improving awareness of triggering factors, and enhancing capacity to respond to symptoms without catastrophizing or avoidance. While the evidence base for mindfulness in FND specifically is limited, mindfulness components are increasingly integrated into multidisciplinary treatment programs based on positive effects observed in related conditions. When evaluating emerging therapies for FND, several principles should guide clinical decision-making. First, novelty should not be equated with efficacy. New approaches generate enthusiasm, but without rigorous trial evidence, their benefits remain speculative. Second, patient selection is critical. Emerging therapies may be most appropriate for patients who have not responded to established evidence-based treatments rather than as first-line interventions. Third, potential harms must be considered alongside potential benefits. Novel treatments may have unexpected adverse effects, and the time and resources devoted to unproven approaches represent opportunity costs that could be invested in established treatments. Fourth, shared decision-making ensures that patients understand the evidence base, or lack thereof, for proposed interventions and can make informed choices aligned with their values and preferences. Now let's discuss professional considerations and ethical issues. Providing effective ethical care for patients with FND requires attention to professional boundaries, communication skills, and ongoing reflective practice. The complexity of FND, its historical associations with psychiatric stigma, and the challenges of managing patients who may have experienced invalidating healthcare encounters create unique professional demands. Therapeutic boundaries require careful attention in FND care. The importance of building trust and therapeutic alliance with patients who may have experienced dismissive treatment can create pressure to extend beyond typical professional boundaries. Clinicians must balance warmth and engagement with appropriate limits that protect both patient and provider. Boundary considerations include clarity about the scope and duration of treatment, appropriate use of communication channels outside appointments, management of patient expectations, and recognition of countertransference reactions that may affect clinical judgment. Communication skills are essential for effective FND management and extend beyond the initial diagnostic conversation. Throughout treatment, clinicians must navigate discussions about symptom fluctuations, setbacks, and the challenging work of rehabilitation. These conversations require honesty, balance with compassion, clarity balanced with acknowledgement of uncertainty, and directness balanced with sensitivity to patient emotional responses. The ability to maintain therapeutic alliance while delivering difficult messages represents a core clinical competency. Reflective practice supports ongoing professional development and helps clinicians recognize their own biases, assumptions, and emotional reactions. Working with FND patients can be challenging, and clinicians may experience frustration when treatment does not proceed as expected, skepticism about symptom genuineness despite intellectual acceptance of the diagnosis, or countertransference reactions to patients with complex trauma histories. Regular supervision, peer consultation, and personal reflection help clinicians recognize these reactions, understand their origins, and prevent them from negatively affecting patient care. Ethical considerations in FND care include respect for patient autonomy, promotion of patient welfare, avoidance of harm, and fair allocation of healthcare resources. Respecting autonomy means providing patients with accurate information about their condition and treatment options, supporting informed decision-making, and honoring patient choices even when clinicians disagree. Promoting welfare requires offering evidence-based treatments that address both FND symptoms and co-occurring conditions, advocating for patient access to appropriate services, and attending to the psychological and social dimensions of illness alongside the physical. Avoiding harm includes preventing iatrogenic injury from unnecessary investigations or inappropriate treatments, communicating in ways that do not compound feelings of invalidation or stigma, and recognizing when treatments are not helping and adjusting accordingly. Fair resource allocation involves balancing the needs of individual FND patients against the needs of other patients, and ensuring that FND patients receive their fair share of healthcare resources without displacing others who also have legitimate claims. Now we arrive at our sixth and final module, where we'll apply everything we've learned through detailed case studies in FND management. The theoretical knowledge and clinical principles covered in the preceding modules come alive when applied to actual patient scenarios. Case studies provide opportunities to integrate information from multiple domains, practice clinical reasoning, consider treatment individualization, and reflect on the complexities and challenges of real-world FND care. For non-specialist clinicians, case studies offer practical examples of how assessment, diagnosis, and treatment principles translate into specific clinical decisions. The following case studies illustrate key concepts from the course and highlight aspects of assessment, communication, treatment planning, and long-term management. Each case is designed to represent patterns commonly encountered in clinical practice, while emphasizing particular learning points relevant to allied health professionals and non-specialist clinicians. Case Study 1: Functional motor symptoms following a physical injury. A 34-year-old woman named Sarah, a former administrative assistant, presents to outpatient physical therapy with right arm weakness and tremor that developed 6 weeks after a minor workplace injury. She reports that she bumped her arm against a filing cabinet, experienced immediate pain, and noticed weakness developing over the following days. She was initially evaluated in an emergency department where imaging of the arm and cervical spine was unremarkable. She was given a diagnosis of soft tissue injury and referred for physical therapy. Sarah describes the weakness as progressive, now affecting her ability to write, use a computer, and perform household tasks. She has been unable to work since the injury. She expresses frustration that no one has been able to explain why a minor injury caused such significant disability, and she worries that she has sustained nerve damage that was missed on initial evaluation. She requests additional imaging and possibly referral to a neurologist or orthopedic surgeon. On examination, Sarah demonstrates give-way weakness of right wrist extension, finger extension, and grip. Strength testing is variable across trials, with moments of near-normal strength followed by sudden collapse. A coarse tremor of the right hand is present that increases with attention and diminishes when Sarah is distracted by conversation. Hoover's sign testing of the lower extremities is normal. Sensation to light touch and pinprick is reduced over the entire right arm in a non-dermatomal distribution, stopping precisely at the shoulder. Deep tendon reflexes are normal and symmetric. Several clinical features in Sarah's presentation support a diagnosis of functional motor symptoms. First, the mechanism of injury was minor and would not be expected to cause the degree of weakness observed. Second, The weakness has features consistent with functional etiology, including give-way pattern, variability across trials, and improvement with distraction. Third, the tremor demonstrates distractibility and entrainment features characteristic of functional tremor. Fourth, the sensory loss follows a non-anatomical pattern, stopping at the shoulder rather than following dermatomal or peripheral nerve distributions. Fifth, there is no evidence of structural damage on imaging that would explain the symptoms. These positive findings allow confident diagnosis of functional motor and sensory symptoms without the need for additional imaging or specialist referral to exclude organic disease. The association with physical injury is consistent with the recognized pattern of FND developing after minor trauma, where the injury serves as a trigger for functional symptoms rather than as a cause of structural damage. Communicating the diagnosis to Sarah requires sensitivity, given her expressed concern about missed pathology and her frustration with the healthcare system. The physical therapist might explain, "Based on my examination today, I found some specific signs that tell me what's causing your symptoms. The pattern of weakness and tremor you have is characteristic of a condition called functional neurological disorder. This doesn't mean your symptoms aren't real, they're completely genuine. But they're being caused by a problem with how your brain is controlling your arm, rather than by damage to your nerves or muscles from the injury." The good news is that because there's no structural damage, the right kind of physical therapy can be very effective in helping your brain relearn normal movement patterns. The treatment plan for Sarah should incorporate several elements based on the principles of FND rehabilitation covered in this course. First, continued education about FND to deepen her understanding and reinforce that symptoms are genuine but amenable to treatment. Second, physical therapy using distraction and automatic movement strategies rather than conventional strengthening exercises. This might include engaging Sarah in dual task activities, using novel movement patterns that bypass the affected arm, and gradually progressing to functional tasks while redirecting attention from the symptomatic limb. Third, addressing any psychological factors that may be contributing to symptom maintenance. Sarah's workplace injury occurred in the context of reported job dissatisfaction and interpersonal conflict with a supervisor, and she describes feeling stressed about finances since becoming unable to work. Referral to psychology for cognitive behavioral therapy may be beneficial, addressing illness beliefs, coping strategies, and the psychosocial context of her symptoms. Fourth, gradual return to work should be a treatment goal, with vocational rehabilitation support if needed. Fifth, development of a self-management plan to maintain gains and manage any future symptom fluctuations. The prognosis for Sarah is relatively favorable given her short symptom duration and the absence of long-standing psychiatric comorbidity. With appropriate treatment and her engagement with the diagnosis and treatment rationale, significant improvement is expected. Case Study 2. Functional Movement Disorder with Comorbid Depression. A 47-year-old man named Michael, a high school teacher, is referred for occupational therapy assessment following diagnosis of functional tremor and dystonia by a movement disorders neurologist. His symptoms began approximately 2 years ago with intermittent tremor of the left hand, which has progressed to include fixed dystonic posturing of the left foot and a broader tremor affecting both upper extremities. He has reduced his work hours due to difficulty writing on the board and reports that symptoms worsen when he is in front of the classroom. Michael describes significant frustration with his symptoms and their impact on his career. He reports low mood, poor sleep, loss of interest in hobbies, and social withdrawal since symptom onset. He reluctantly accepted the diagnosis of functional movement disorder after initial skepticism, though he sometimes wonders whether something has been missed. He takes sertraline for depression, which has partially improved his mood but has not affected his movement symptoms. On examination, Michael demonstrates a coarse, irregular tremor of both hands with variable frequency. The tremor entrains to examiner paced, tapping, and diminishes substantially when Michael is engaged in conversation about topics unrelated to his symptoms. The left foot is held in a fixed plantar flexed and inverted position. Michael reports that the foot became stuck in this position approximately 6 months ago and has not moved normally since. Passive range of motion at the ankle is limited by resistance rather than by true contracture. During examination of the upper extremities, the foot spontaneously moves to a more neutral position, then returns to the dystonic posture when attention returns to the lower limb. Michael's presentation illustrates several important points about FND management. First, his symptoms demonstrate classic features of functional tremor and functional dystonia, including entrainment, distractibility, and variability. The diagnosis is secure based on these positive findings. Second, his comorbid depression is both common in FND and important to address as part of comprehensive management. Untreated or inadequately treated depression impairs rehabilitation engagement and is associated with poorer outcomes. The partial response to sertraline suggests that optimization of pharmacological treatment or addition of psychotherapy may be beneficial. Third, his ongoing diagnostic uncertainty, despite accepting the diagnosis, is common and requires continued attention. Periodic reinforcement of the diagnosis with reference to the positive clinical signs may help consolidate his understanding. Fourth, his symptom worsening in occupationally relevant situations, specifically when teaching, suggests a role for anxiety and self-focused attention in symptom expression. Interventions targeting performance anxiety may be helpful alongside motor-focused rehabilitation. The occupational therapy assessment should use the Canadian Occupational Performance Measure to identify Michael's priority goals, which likely include returning to full-time teaching, writing on the board without significant tremor, and walking without visible limp. Sensory processing assessment may identify patterns that inform treatment planning. The treatment plan should include graded engagement in teaching-related activities, starting with less anxiety-provoking situations and progressively increasing demands. Distraction techniques and automatic movement strategies should be incorporated. Collaboration with psychology for CBT addressing depression, illness beliefs, and performance anxiety is recommended. The prognosis is guarded given the 2-year symptom duration, comorbid depression, and occupational disability, though meaningful improvement remains possible with sustained multidisciplinary treatment. These case studies have illustrated how the theoretical concepts and clinical principles covered throughout this course apply to actual patient presentations. Several overarching themes emerge from consideration of these cases. First, the diagnosis of FND rests on positive clinical findings, not on exclusion of organic disease. Both Sarah and Michael demonstrated characteristic signs that allowed confident diagnosis without extensive additional investigation. Second, communication of the diagnosis is a therapeutic intervention that requires skill, sensitivity, and attention to the individual patient's concerns and understanding. Third, effective treatment requires individualization based on symptom presentation, comorbidities, psychosocial context, and patient goals. While the core principles of FND rehabilitation apply broadly, their specific application must be tailored to each patient. Fourth, comorbid psychiatric conditions, particularly depression and anxiety, are common and require concurrent treatment. Fifth, prognosis is influenced by multiple factors, and realistic expectations should guide treatment planning while maintaining hope for meaningful improvement. Sixth, multidisciplinary collaboration enhances outcomes by ensuring comprehensive care and consistent messaging across providers. We will now review the exam questions to solidify your understanding of the key concepts covered in this continuing education course on functional neurological disorders for the non-specialist clinician. Question 1. Which of the following statements best reflects the contemporary approach to diagnosing functional neurological disorders? The correct answer is C. FND diagnosis should be made on the basis of positive clinical signs rather than exclusion of organic pathology. Rationale. Modern diagnostic practice has shifted away from the outdated approach of diagnosing FND only after exhaustive testing fails to reveal an organic cause. Instead, clinicians now recognize that FND can and should be identified through the presence of specific positive clinical signs, such as internal inconsistency and incongruity with patterns seen in recognized neurological diseases. This rule-in approach is more accurate, leads to earlier diagnosis, and avoids unnecessary testing that can delay appropriate treatment and reinforce illness behavior. Question 2. Hoover's sign is a validated clinical test used to identify functional leg weakness. Which finding during this test supports a diagnosis of functional weakness? The correct answer is A. The apparently weak leg demonstrates normal downward pressure during contralateral hip flexion against resistance. Rationale. Hoover's sign relies on a fundamental principle of motor physiology. When a person attempts to flex one hip against resistance, the opposite leg automatically pushes down as a synergistic stabilizing movement. In functional weakness, this automatic downward pressure in the supposedly weak leg is preserved, demonstrating that the motor pathways are intact. The weakness only manifests during direct voluntary testing of that limb. In contrast, a patient with true organic weakness would show reduced or absent downward pressure in the affected leg during this maneuver because the neural pathways are genuinely impaired. Question 3. According to the predictive coding model of FND pathophysiology, symptoms arise from which of the following mechanisms? The correct answer is D. Abnormal top-down predictions that override normal sensory feedback through intact motor pathways. Rationale. The predictive coding model represents a significant advancement in our understanding of how the brain generates FND symptoms. This model proposes that the brain constantly generates predictions about expected sensory and motor experiences, and these predictions are normally updated based on feedback from the body. In FND, abnormally strong internal predictions, sometimes called priors, override or suppress the normal sensory feedback signals. This creates a mismatch where the brain's expectation of dysfunction overrides the actual intact function of motor and sensory pathways. Crucially, this mechanism explains why FND symptoms are involuntary and genuine, not consciously produced, and why interventions targeting attention, expectation, and belief can modify symptoms. Question 4. The Physio-4-FMD randomized controlled trial comparing specialist physiotherapy to community-based neurological physiotherapy for functional motor disorder found which of the following? The correct answer is B. Significantly more participants in the specialist physiotherapy group self-rated their motor symptoms as improved compared to the control group. Rationale. The Physio-4-FMD trial was a landmark study that provided important evidence for physiotherapy in functional motor disorder. While the primary outcome measure, the SF-36 physical functioning subscale, did not reach statistical significance, the secondary outcomes told a compelling story. Participants who received specialist physiotherapy were significantly more likely to report that their motor symptoms had improved compared to those receiving standard community-based neurological physiotherapy. Additionally, the specialist physiotherapy group showed better mental health scores and improved subjective well-being. These findings support the value of specialized, FND-informed physiotherapy approaches. Question 5. Which of the following instruments is a patient-reported outcome measure that assesses 5 dimensions including mobility, self-care, usual activities, pain and discomfort, and anxiety and depression? The correct answer is A. EQ5D5L. Rationale. The EQ5D5L is a standardized, generic health-related quality of life instrument developed by the Neurological group. It captures patient-reported health status across 5 essential dimensions of daily functioning and well-being. The 5L in the name refers to the 5-level severity scale used for each dimension, ranging from no problems to extreme problems. This instrument is particularly valuable in FND because it captures the broad impact of the condition on multiple aspects of a patient's life. The other options listed, the Timed Up and Go test, Berg Balance Scale, and 10-meter walk test, are all clinician-administered objective performance measures rather than patient-reported outcome instruments. Question 6. Which of the following represents a significant barrier to implementing effective multidisciplinary care for FND at the provider level? The correct answer is C. Lack of education and expertise among healthcare professionals regarding FND recognition and management. Rationale. Despite FND being one of the most common conditions encountered in neurology clinics, many healthcare professionals receive inadequate training about these disorders during their foundational education. This knowledge gap leads to several problems, including delayed or missed diagnoses, inappropriate treatment approaches, and communication with patients that may inadvertently undermine their confidence in the diagnosis or treatment plan. Persistent misconceptions about FND, such as viewing it as malingering or a diagnosis of exclusion, further compound this problem. Addressing this educational deficit is essential for improving outcomes for patients with FND. Question 7. Regarding emerging therapies for FND, what has research demonstrated about eye movement desensitization and reprocessing, or EMDR? The correct answer is B. The modified trial demonstrated that EMDR is feasible, acceptable, and showed potential benefits including reductions in PTSD symptoms, depression, and anxiety. Rationale: the MODIFY trial was a randomized feasibility study designed to evaluate whether EMDR could be successfully adapted and delivered for patients with FND. The results were encouraging. Patients found the intervention acceptable, and the study demonstrated that conducting EMDR in this population is feasible. Participants who received EMDR showed reductions in several important outcomes, including symptoms of post-traumatic stress disorder, depression, anxiety, dissociation, disability levels, and healthcare utilization. However, because this was a feasibility trial with a relatively small sample size, larger randomized controlled trials are needed before EMDR can be established as a standard treatment for FND. The findings provide a strong foundation for future research. Question 8. Which clinical finding is characteristic of functional visual loss and can be demonstrated at the bedside using confrontational visual field testing? The correct answer is D. Tubular vision with non-expanding visual fields regardless of testing distance. Rationale: tubular vision, also referred to as tunnel vision with non-expanding fields, is a classic and highly specific positive sign for functional visual loss. To understand why, consider how normal visual fields work. The visual field is essentially a cone that expands outward from the eye. As the distance between the patient and the testing target increases, the area of preserved visual field should expand proportionally. This is true for both normal visual fields and for visual field defects caused by organic lesions, such as retrochiasmal pathology. In functional visual loss, however, patients report a fixed area of preserved vision that does not expand as the testing distance increases. The result is a tube of vision rather than a cone. This finding is physiologically inconsistent with any organic visual pathway lesion, and is therefore a reliable positive clinical sign that can be demonstrated at the bedside without the need for specialized equipment. Other options described organic patterns such as field defects that expand proportionally with distance, hemianopias following anatomical lesion patterns, or scotomas corresponding to optic nerve distributions. These are all consistent with structural visual pathway disease, not functional visual loss. Question 9. Which of the following is a core behavioral intervention component of cognitive behavioral therapy, specifically adapted for FND? The correct answer is A. Graded behavioral activation to gradually increase engagement in avoided activities. Rationale: cognitive behavioral therapy adapted for FND incorporates specific behavioral strategies that directly target the activity avoidance, excessive rest, and safety behaviors that commonly develop in patients living with functional symptoms. Many patients with FND progressively restrict their daily activities because they expect that physical or cognitive engagement will worsen their symptoms. Over time, this avoidance leads to physical deconditioning, social withdrawal, and reinforcement of the sick role, all of which perpetuate disability. Graded behavioral activation is a structured, systematic approach in which patients gradually and progressively increase their engagement in activities they have been avoiding. By doing so in a controlled, stepwise manner, patients learn through direct experience that activity does not necessarily worsen their symptoms, which helps to challenge and update the maladaptive beliefs and expectations that were driving avoidance in the first place. This aligns directly with the predictive coding model discussed earlier, as it works to modify the abnormal predictions that underlie symptom production. The other options listed, including hypnotic regression, dream analysis, and free association, are psychoanalytic techniques that are not components of cognitive behavioral therapy. Question 10. Which factor is most consistently associated with favorable outcomes in patients with FND? The correct answer is D. Shorter symptom duration at the time of diagnosis and treatment initiation. Rationale: across the FND literature, shorter symptom duration at the time of diagnosis and the initiation of appropriate treatment is the factor most consistently linked to better clinical outcomes. Patients whose symptoms have been present for months rather than years are significantly more likely to achieve substantial improvement with intervention. This finding has profound implications for clinical practice. It underscores the critical importance of early recognition of FND, timely and confident delivery of the diagnosis, and prompt referral to appropriate evidence-based treatment. Every delay in the diagnostic and treatment pathway, whether caused by unnecessary investigations, diagnostic uncertainty, or lack of available services, potentially allows symptoms to become more entrenched and resistant to intervention. Longer symptom duration is actually associated with poorer outcomes, and neither older age at onset nor untreated psychiatric comorbidity are the most consistently favorable prognostic factors. This is a powerful call to action for all clinicians, including non-specialists, to develop the skills needed to recognize FND early and to initiate appropriate care without unnecessary delay. This concludes the exam review. You have now reviewed all 10 questions, the correct answers, and the rationales behind each one. Take a moment to reflect on any areas where you felt less confident, and revisit the relevant course material before completing your examination. Good luck!